Jade Malco Bryan will be presenting the second case. So we'll have a couple of switches. Jade's with me here, and Brian is down at Emory, I believe. So I'm going to let him know he's second case, not the first case. 1 second.
All right. I'm going to get started. Hi, guys. I'm going to talk about a patient that we saw on the toxicology service just last week. He's a 58-year-old male who presented voluntarily to our emergency department to seek help for quitting alcohol. He was very concerned about that he would die on his own. He has never tried to detox before and has no history of seizures, but has heard that this could be a hard thing to do. His last drink was 10 minutes before he came in. He has a long-standing history of alcohol use, has been drinking almost daily since his teens, but kind of different phases of kind of types of alcohol quantities and kind of what he would binge with. He reported to us that he was drinking maybe 4 to 5 kind of the concentrated IPA beverages every day, mostly socially, but sometimes on his own. His girlfriend actually said to him, "I think you have a problem," and wasn't willing to stay with him, but didn't give him much of a chance to change his behavior and just left, which sent him into a spiral. So he had been drinking half a liter to a liter of liquor a day. He does have a history of cocaine use, a lot kind of younger when he was growing up in the 70s, but did report he had used during his binge the week before. Denied any history of opiates and no recent tobacco or THC. He was on a couple of maintenance medications and which he was taking. Kind of in his interview, like I mentioned, had never been involved in any kind of outpatient or inpatient chemical dependency. He kind of classified himself as a functional alcoholic, never had any issues with the law or with work. He was a supervisor for a power line company, and he kind of was smart enough to know he couldn't drink before he went into work, or couldn't at least appear intoxicated because he wanted to avoid any kind of formal violations. But his coworkers, who were also his roommates, said, "I think you have a problem. You should probably get some help." So they were supportive in him coming to the ED for evaluation. So when he first came in, vitals are.
I think it's just slow. 1 second. There we go. His vitals weren't
significantly abnormal. I did read kind of through the course of the record at times he was a little more hypertensive, had some tremor, appeared anxious, labs fairly unremarkable, a little bit of signs of dehydration and maybe some minimal transaminitis. His alcohol was 77. And his urine tox was only positive for cocaine. So the ED kind of began management, but had asked for some recommendations, and I wanted to kind of take this time to talk about kind of practice patterns for different options for treatment of alcohol withdrawal, and then we'll kind of move on to treatment of kind of craving and maintaining abstinence. So for this patient, he was actually put on a Valium taper, but in the past we've also considered using phenobarb. And would you guys have any preference towards one of those protocols versus another, or use any other medications to help?
Thank you. We'll take a kind of break here and just use this time to talk about what are the different protocols or standards that, you know, those of you have on the phone for alcohol withdrawal management in the emergency department. Just raise your hand, and maybe Tricia, you can unmute. Does anyone want to describe their standard protocol?
if you want to even describe inpatient versus outpatient plans as well, there's some variations in those.
Okay, Derek, let's see if we can unmute you. Go ahead.
Hey, sorry, Tim. Hey, Christopher, go play. I'm sorry, I got the boys here. So in the ED, you know, we try to identify these patients as soon as possible, even the ones with some minor withdrawal symptoms, but with major tolerance to try to avoid any problems or have them have to come in the hospital for treatment. So, you know, I'm pretty liberal with Librium, and I'm pretty comfortable with phenobarb just because a long time ago that was our go-to medication. So I usually have a conversation with the patients and just kind of see if they've had experience with those in the past and if they have a preference. But usually I'll do like 50 to 100 of PO Librium, presuming they're not having any GI symptoms, or, you know, I'll titrate them with phenobarb, the 130 of phenobarb every 15 minutes or so, get them titrated. With the Librium, we usually reassess them in about an hour just to kind of see where they are, if they're having some improvement. Clearly, you want to make sure that they're not becoming sedated or that they're moving in the wrong direction, but really that you're having improvement with their symptoms and kind of stabilizing them. And then maybe after that, depending on what else they came in with, kind of reassessing what your discharge plan might be with them as far as potentially outpatient medications, follow-up, et cetera.
That's good. Sounds like you've got a couple of different options and, you know, may use one or the other. Thank you, Derek. Who else says, does anyone want to, let's see, Henry. Keith, actually, Keith Burkhardt, you're unmuted right now, then we can go to Henry.
Yeah, I don't really do the outpatient stuff, but from the inpatient, I usually handle this. Is somebody like this who's just coming in and you're not sure exactly with the level where he is, and that's still if he's going to accelerate more. So I typically start with more Ativan, lorazepam, and see what kind of doses he responds to, looking for, you know, sleepiness and drowsiness coming with those early doses, suggesting that it's not going to be severe withdrawal. But if you're needing a lot and start accelerating, I've sometimes added in a little bit of some doses of haloperidol to get some synergism in that there. But if they start to accelerate, I've quickly moved on to phenobarb for patients who look like they're going to have severe withdrawal. Thank you.
Good, thank you. Henry, how about you?
Yeah, so for the most part, I think we get people started on our inpatient, CEWA directed protocol in the emergency department. I think is most people's first step, and our protocol starts with PO Valium, 10 milligrams for a CEWA over 8 or 20 for a CEWA over 15 every 2 hours. And I think, I usually people will get a dose of that Valium, before we get involved with them or before we start worrying too much. If they're already kind of amped up, we'd certainly start with IV Valium. I think a lot of people would, or maybe, if I'm advocating for them with an IV phenobarbital, either load 10 milligrams per kilogram or a push if they're already like in severe withdrawal. But if they're just starting to withdraw and I'm concerned about their tolerance, a lot of times they'll get that like first dose of Valium, and we'll see how they do. Again, if they get pretty sleepy with that, well, I'm not super concerned with where they're at least at the moment. And then, if it doesn't touch them, then we kind of keep just working on our protocol where, again, we're getting 20 of Valium every 2 hours. And a lot of times these guys who if I'm really worried about them and I go down and I consult on them, I'll do that 10 milligram per kilogram phenobarbital load. If I'm not so worried about them, or they're not yet, or they've made their way out of the ER and they're on the floor and we don't want to do an IV load, a lot of times I'll kind of do another kind of test dose sort of thing, and I'll start them on 100 of phenobarb QID orally and see how they do with that as kind of a prophylaxis and a slow sort of load. And if they start getting a little sedated and aren't needing their Valium, and then we can just pull it off. And if they escalate, we can escalate with that as well. But I think that's our kind of typical approach in the ED.
That's great. Thank you. Does anybody have any other questions or comments or want to share their protocol? Now, there's certainly more than one way to approach alcohol withdrawal in the emergency department. We heard on the oral comments about oral long-acting agent, IV long-acting agent, different benzodiazepines, plus or minus phenobarbital. Does anybody have go-to with phenobarbital as the first line? Einstein toxicology. Go ahead. You're unmuted. We're having trouble hearing you from Einstein. Maybe if you type in a comment, I can read that. Otherwise, we're not able to hear. So, yeah, our protocol at University of Rochester will vary depending on who's picking the patient up. Often, if the toxicology service gets involved, we'll come down and see the patient at the bedside and administer phenobarbital incrementally using a protocol that is similar to what's used at Highland Hospital in Oakland, based on some of their publications in the Annals of Emergency Medicine, titrating basically to effect. In some patients, as Henry had mentioned, that are more severe, we'll use a milligram per kilogram load. We've not gone up to 1,000 right away. I usually will use a lower dose, but then they often need some additional dosing. And then they're left on CEWA once they are admitted. We'll also use some adjunctive medications, and I heard Keith Burkhart mention Haldol. I usually don't do that early on. We'll add clonidine more for anxiety as a sympatholytic, like 0.1 Q6 PRN for anxiety, but not as a benzodiazepine replacement, as more of a sparing agent to try and help get rapid control. So both Henry and Einstein, you're still unmuted if you want to try. Are you able to hear us?
Yeah, so this is Henry again. Einstein on? You guys want to talk?
Yep, go ahead. Well, Einstein, I think we can't hear right
now.
Okay.
So yeah, speaking of adjunctive medications, I do use gabapentin from time to time, like you said, as kind of like a benzodiazepine sparing. They're still on the CEWA, and I want them to get benzos. But for that patient who I'm like, your withdrawal isn't so bad, your anxiety that's not related to withdrawal is so bad, I just put on 600 TID of gabapentin in addition to their CEWA-directed benzodiazepines as just something they can count on. They know they're going to get that gabapentin, in another 8 hours, and hopefully that'll help them tone down a little bit.
Great. That's good comments. Our burn trauma ICE units will often add gabapentin even prior to the onset of withdrawal for patients that screen high at risk of severe alcohol withdrawal. They'll implement 600 milligrams TID as a prophylaxis, and then they continue that if they do go into withdrawal, but it tends to make the withdrawal severity, the likelihood of going into withdrawal decreases and the severity decreases anecdotally from their reports. Dr. Bishevitz, through strong recovery, you have some potential ambulatory detox. You've been involved in the outpatient setting, and at Norris, maybe you can comment a little bit on your alcohol withdrawal protocol in those settings.
I know that at Norris Clinic, which is an inpatient clinic, they use phenobarb preferentially for alcohol withdrawal, and often, of course, it's a mixed picture of alcohol and benzos or other things. But I think one of the reasons that they do that over there is they don't want to have a lot of, they've had a lot of contraband problems with the inpatient rehab, and they want to use the least amount of benzos, the better. So they figure that phenobarb is better for that. But that's done by the medical staff over there. On an outpatient basis, we have not done very much alcohol withdrawal at all. We might tend to use agents like Librium or Valium, chlordiazepoxide or diazepam, and so we mostly do opiate withdrawal.
All right, let's move on in the case.
So I wanted to talk a little bit about gabapentin. This patient, we actually didn't use it on, but kind of exploring our options for benzos and kind of inpatient and outpatient regimens. I came across a paper that was published in 2008. Actually, it looks like it might be 2009. I apologize. But it compared 4 days of gabapentin and lorazepam for the treatment of alcohol withdrawal. These patients seem to have been more like mild to moderate, CWAS scoring more than 10. But the overall doses of medications that they were using were relatively low, in the realm of starting them at either 900 or 1,200 milligrams of gabapentin daily, split TID, and then lorazepam, 6 milligrams split TID was kind of what it was compared to. And it seemed to be as effective. And I found this interesting using gabapentin as an isolated agent for mild to moderate alcohol withdrawal. And I wasn't sure if anyone else has either seen this paper or done something like this. I find it, as an emergency physician, when I think about can a patient go home with medication, I hesitate to give someone that's actively drinking benzos to go home with. I worry about if they're going to co-ingest and kind of respiratory depression and bad outcomes. And these patients seem to like benzos as much as their alcohol, and I just don't I feel a little concerned about that. So I find gabapentin in relatively low doses an interesting option, and I have not done it myself. I can't speak to its effectiveness, but this is 100 patients, and they actually showed that 12 days after, the gabapentin-treated patients actually did better than lorazepam for staying away from alcohol as well.
All right, Henry again, although we've got Henry, after your comments, I'm going to encourage some of the others. I'm going to start calling on some people as well. I know you do a lot of this, but so go ahead.
Sure. Yeah. Sorry, I'm just talking since nobody else was. I've looked at it, and that's why I like to get the gabapentin started on people, because then I will continue it to decrease their drinking, hopefully, in the outpatient setting. But my look back at the literature when I was looking at its use as a primary agent, and sure, people have used things like carbamazepine or gabapentin, but neither of those things, despite being anti-epileptics, have been shown to decrease seizures in alcohol withdrawal or to decrease DTs. So again, I mean, it's probably okay to decrease the symptoms of withdrawal for a patient who's probably going to be fine anyway. But I don't see it as a therapy that's really going to improve outcomes in a patient I'm worried might have severe withdrawal.
Yeah, those are great comments. Keith, you have a follow-up?
No, well, I just wanted to ask a question for experience in this, because I've really not used gabapentin that much, and more so I've treated a number of patients that end up having withdrawal, sometimes severe, and that from gabapentin. And so I was just curious about experiences in putting somebody on this, and how long you might keep them on it, and difficulty in tapering them off, and all those kind of things that may come with gabapentin. So I was just curious for some other people's experiences.
Sure. So I'll comment a little bit about our practice or my practice, and then maybe we can get some other feedback. And I've seen there was a recent paper announced probably a couple of years out that showed in individuals with alcohol use disorder, a dose of 600 milligrams TID prevented drinking and decreased drinking severity. It was a 12-week study. I think the number needed to treat was 7 for one individual to go 12 weeks without returning to alcohol use. There's some other data that shows it may help with alcohol craving. Now, this is in only alcohol use disorder. from what I've seen of the study and the inclusion criteria and exclusion criteria, they weren't polysubstance, cocaine, opiates, other things. So I tend to use gabapentin only when I've only got alcohol use disorder, and I consider it potentially as an alternative to a camprosate with then naltrexone often. But I know of several different areas in the hospital and one of the local jails or clinics that uses it prophylactically for 5 days, a 600 milligram TID before, when patients are screened at high risk for going into withdrawal, preemptively to try and limit the risk that they do go into withdrawal or that its severity. So I agree with Dr. Swoboda about the risk not using, benzodiazepines or barbiturates when you have severe withdrawal potentially. So adjunctive agents really should be kept adjunctively. And I have seen really bad, fairly high level gabapentin use dependence and then with abrupt cessation withdrawal as well. Let's see, Ingrid, you're on, I see. Do you have any comments or you want to give us your perspective about this?
No, I don't have any comments. I don't treat alcohol withdrawal all that often anyway, so I'm learning from everybody else's experience. Thank you.
Sure.
And I like the point that even the carbamazepine and some of the anti-epileptic category agents, they have not shown to decrease the risk for seizures. And I think we have to be really careful about what patients we choose to kind of, if we do want to use gabapentin as an adjunct, kind of making sure that we're not under-treating. That's important.
So let's go back to the patient's course.
So he was discharged from the hospital on hospital day 4 after finishing his Valium taper. He actually was not on gabapentin. We used kind of, he didn't require that much Valium while he was in the hospital, but he eventually be able to discharge home. He was agreeable to starting some medications for alcohol craving. And kind of while he was in the hospital, we addressed his underlying depression and anxiety contributing to alcohol, and his SSRI was changed. And his plan was to kind of attend AA. He was going to follow up with an outpatient chemical dependency evaluation and his primary care doctor.
Here, let me stop for a second. One of our rotators is a senior psychiatry resident who had noticed that he was on a very small dose of fluoxetine and had some thoughts about underlying anxiety. Maybe you can comment.
Hi, yeah, we had switched the Prozac to the Lexapro because he was on a really small dose. And we had talked about how usually with SSRIs, we try to only increase them in increments like every 4 to 6 weeks. And Lexapro tends to get to a therapeutic dose a lot quicker. So we switched him over to Lexapro. And then when we saw him, I think you're going to go into outpatient when you saw him. I'll let kind of Jade talk about that.
But we did start the naltrexone and decamprosates in the hospital in the ED setting, and have been looking at doing this in more patients with alcohol use disorder, bridging to follow-up, and then looking at how do we do that and coordinate follow-up, because some of the patients show up to their primary care doctor, and we've had a couple of them abruptly stop saying, well, I don't do this, I don't know how to do this, I don't, even with the discharge summary sent, and start looking at maybe using our toxicology clinic, like similar to opioid use disorder for stabilization for some of these patients if they don't have a program, for example, or primary that's comfortable. So, Jade, you'll talk a little bit about options for pharmacotherapy for alcohol use disorder.
Yeah. So, like Tim mentioned, this patient was started on a TID dosing regimen of acamprosate. And then was also very good about taking his naltrexone daily. As everyone already knows, the naltrexone has the PO and IM formulations. It's rather difficult for us to facilitate, initiating someone on IM Vivitrol from the hospital, mostly because it's just not carried on formulary. It would be something that would be nice that we could do, and something that I'm hoping we can explore for both opioid use disorder and alcohol. But he was discharged home on daily naltrexone. Disulfiram in general, I I mean, I'm fairly early in this, in my training here, but I have not used it and have heard very few success stories with it. Interested to see if anyone has any thoughts about what patients might benefit from that. And like we touched on, kind of as part of his medication-assisted treatment, addressing his mental health is really important. I'm going to touch on, we can take a minute to talk about different options of what people are using right now.
I'm wondering, from our addiction psychiatrist perspective, you know, do you think it's an opportunity for starting a patient like this, Dr. Bishevitz, in the ED or in the hospital on alcohol craving medications, or do you see pros and cons of something like this?
I think it's wonderful. There's no wrong door to this. You would probably tend to start acamprosate or naltrexone preferentially rather than disulfiram, of course. But there is still a place for disulfiram when someone is in an ongoing program. We do use it in methadone maintenance because it, well, it's not an opiate blocker for one thing. So because our methadone patients can't take naltrexone. And when they don't succeed on something like acamprosate, we sometimes will give them disulfiram mixed in with their methadone, since disulfiram is available as a liquid. So we do use it in that way. But I really think there's very, very little side effects or downside associated with acamprosate or naltrexone. I mean, there's a few things like nausea, but people can just stop it if they get that. So if they want to be prescribed it in the ED, I don't see a problem with it.
That's a great comment. Ken, Dr. Towner, you have, working with a lot of these patients in the past, clinically and at the VA. Do you have any comments or thoughts about some of these pharmacotherapies for alcohol craving?
I don't really have anything to add to what Gloria said. Yeah, no.
There have been a couple of scenarios in the emergency department where I've actually prescribed disulfiram to someone that is going to follow up in an outpatient clinic, and they've only been when there's a significant other that has asked about it and wanted to be kind of brought into the treatment. So we had or the patient has requested, well, what about the one I think if I know it'll make me sick, I'm not going to drink, so kind of leveraging, well, this is where you can get your significant other to give you the medicine, and it works very differently than an anti-craving medicine. So that, and I don't recall kind of how, if, there was a limited success in that. I think in both cases, it seems to me the patient kind of fell off, but so we really don't consider a frontline option.
So yesterday I saw this patient in follow-up clinic, and he had kind of come to some interesting conclusions about how he was willing to kind of engage in therapy. He had gone to a couple AA meetings and said, yeah, I felt okay when I went, but they didn't seem to help me all that much, and I don't think I believe in pure abstinence. He had kind of set the stage for taking his dog for a walk and stopping at a bar to enjoy an IPA on a relatively normal day for him, and he had made the choice that this was going to be, he wasn't willing to kind of give that up. He really wanted to explore if he could engage with more of a harm reduction model of being able to drink less, and we discussed our concerns about that, especially so early in his first kind of go at treatment. But we're trying to kind of meet him where he's at right now in an attempt to at least keep him engaged with his psychotherapy, and he's following up with his primary care doctor. He's willing to continue the craving medication. And has anyone else had any patients that have kind of been a little bit more resistant to pure abstinence, and how have you worked with them to either achieve their goals or get them abstinent in the long term?
This is Tim. I had a colleague who had known about naltrexone and had recommended for a friend of his in his and a family member that he used naltrexone to kind of curb the alcohol use when they went out socially because they tended to overdrink. Not that there was a full dependence, probably binge drinking certainly, and apparently it happened, more than they were able to modulate use by just trying to do so. So I noted that it helped kind of cut down the drinking. So, and I've seen people use this kind of without the full intention of stopping, just to kind of dampen down the reward. So you're shaking your head, yes?
Yeah, I think it's more common in a PCP prescribed setting rather than, say, a chemical dependency program setting. But because most chemical dependency programs work at abstinence as a gold standard, but still, it seems very useful for decreasing the amount of drinking. That is what the research studies say. That's the test that they use to measure it is how many drinks per week. That's what decreases when you take naltrexone. So it seems like a no-brainer in a way, and it's certainly one of the tools that we have.
Yeah, I think this gentleman seemed a little, anxious that we were going to be upset that, he expected, I think, you're not going to do the 12 steps, or he had a belief of what an addiction provider would be, how they would interact with him. So I think he was happy. You could see kind of this relief saying, we're hoping your health improves. And, I think if you keep drinking, it's, maybe higher risk that you progress. But, if you're drinking less, that's great. Something to work at. I did think about gabapentin in this individual, but he had gone on a cocaine binge. And when you have polysubstance dependence, usually worse opioid use disorder, where most of the gabapentinoid abuse is, I just get uneasy and adding another sedative. It tends to just get thrown in the mix instead of taken appropriately. And it may be something if the naltrexone isn't working. He seems fine with taking a tablet. I'd rather get the monthly depot injection, but this is good. And a very simple follow-up I think was very valuable. He did call for an intake in an outpatient treatment program, but he travels a lot, and so he's not going to be able to, get to regular appointments in groups. So having somebody, with nuanced specialty experience available to check in with him, we'll measure ethylglucuronide when it comes in, check to see if he's using cocaine. Maybe we can see, how he's doing. So he's set for essentially 5-week follow-up in the tox clinic, and we'll see how he does and kind of work with him over time.
Okay. I just want to mention, because I realize a lot of you on the webinar may not actually talk with chemical dependency counselors on a regular basis. And actually, all these things Tim mentions are actually accessible within a chemical dependency program, because they have changed. The orientation of counselors and also of state agencies that regulate them have changed dramatically over the years, to where we could have a person like this come into a state-regulated chemical dependency program, and it would be just fine. He'd be telling his counselor, well, I still want to drink in naltrexone, and the counselor might say, okay, well, let's talk about that, or maybe you should try doing a trial of abstinence for a few weeks to compare it with your drinking weeks, or something like that. So in other words, it's kinder and gentler than it used to be, and this patient has a fantasy of how it used to be, the heavy AA emphasis and the pure abstinence. And believe me, when I came into this field in 1986, there were people who were discharged from their programs for just one drink. So it definitely did exist, and there's just been a sea change ever since. And also the thing that Tim mentioned about traveling, the guy who's traveling, not all chemical dependency programs require groups. Sometimes there's openings for individual therapy. So a lot of options.
Yeah, those are great points. But I also recommend that he was interested in a counselor for mental health too, and he was taking the SSRI, that he may be able to engage with someone using telemedicine or Skype. One of my patients in the Tox Clinic has been stable on buprenorphine, has a monthly encounter with a counselor through Skype. I think she's separately, but where it works, there's a lot more opportunity for engagement. Let's see. Ingrid, you've got your hand up. Do you have comments or questions involving this case?
Yeah, I just have a couple of comments on two very critical terms that I heard. One was harm reduction, and the other was working with where the patient's at. And I think there's been some discussion around that in terms of improvement over the last little while, but I certainly see that in the opiate-dependent patients. And I think the key thing is not so much the abstinence or whether they're continuing to use whichever substance. If they remain engaged and they're taking the either opiate or alcohol related sort of substance use treatment, that at least they remain engaged, and that's probably more important than feeling turned off and then going away and continuing on with what they were doing previously. So I would agree in terms of we've certainly loosened the reins quite a bit to say, okay, well, it's not working 100%, but at least it's providing some degree of harm reduction. And if that's the best we can do for this patient at this point, then that's what we're doing. And when they're ready, they may progress to a different stage.
Yeah, good comments. Thank you. Definitely, I've seen the same thing, and just not having done this for as long, even remotely, as some of those of you on as well. Since getting the waiver, buprenorphine waiver, I've seen a big change from use of THC or cocaine to how do you work with patients instead of just cutting them off. All right, we're going to move on because we've got a great second case. Dr. Murray, Senior Tox Fellow at Emory. I can advance the slides for you if you present the case.
Okay, awesome. Sounds good. Hey, everybody. So, different slide background. So this was a patient that I saw in a community hospital. This was a 23-year-old female. She came in with abdominal pain. 3 months prior, she'd had a colectomy for, I'm not going to say it, so it's BAP. And she currently had ileostomy. She had multiple ED visits over the last just couple weeks for pain, multiple pain medication refills, with very poor follow-up with her surgeons that were about a hospital about 45 minutes away from us. She complained that she was currently out of pain medication, but her last use was last night, and she was in a bunch of pain. So her main complaint, some nausea, vomiting, some hot and cold flashes, body aches, mildly decreased output from her ostomy, but it was still outputting stool. Okay, next slide. Vital signs, a little bit tachycardic, normal blood pressure, heart rate, no fever, or hyperthermia. Her ostomy appeared normal. I didn't see any redness, inflammation, tender abdomen with a little bit of guarding, but no rigidity. Next slide. So I did a CALS on her. We don't really have much follow-up down where I am when I work in the community. However, there's always the thought that maybe if they're able to make it up to our main buprenorphine clinic up in Atlanta, that I'd be able to maybe start them. So she had some decent withdrawal. She had a pretty good story for it. I didn't think she was necessarily a true opioid use disorder yet, but she had some pain that was likely chronic pain, and she was heading down the wrong direction. I was thinking buprenorphine might be a good option for her to help her out. Next slide. So any thoughts or ideas at this point in time, other than what I've talked about? I mean, would people consider her a candidate for buprenorphine at this point? Or just give her some more pain medications?
Just raise your hand. I'll just start. I think I see a lot of people coming into the emergency department that have either chronic pain or acute pain or post-surgical, and usually the default is quick, while the patient's getting worked up, they'll get a dose of morphine or hydromorphone or hydrocodone or something, and then as the history is reviewed and things are considered in more detail, someone, one of the residents may say, on the tox service I saw, that we started some of these patients on Suboxone, buprenorphine, and they seem to do better. They seem to, do well. Maybe we should try that in the ED. So we're getting, a lot more requests for, is this patient appropriate for buprenorphine in the emergency department, and a lot broader background, not just simply I'm an IV heroin user and I'm sick and I'm withdrawal and I need something, but, a lot of other context.
Yeah, anecdotally in our own, sorry.
Oh, go ahead, and then Ingrid can comment after.
Just anecdotally in our own clinic up at Grady, we're starting to get more people who are chronic users. Some of them have gone to get heroin because it's easier and cheaper to get a hold of, but some are really just chronic pain patients, and the pain medications aren't helping them. And the buprenorphine seems to actually control their pain quite a bit better, probably because it's not really a pain issue. It's more of a sort of hyperalgesia, chronic opioid use problem causing their pain. And so I'm kind of on the lookout for these patients to some degree.
Go ahead, Ingrid.
Well, I guess it depends on what your ultimate goal of therapy here is. Are you considering buprenorphine for pain relief? Do you think she has an opiate use disorder and she's actually getting other drugs on the street because she's running out of her other pain medication? Is she out of her pain medication because she's using much more quickly than she was supposed to? So if you think that the buprenorphine is really helpful for pain, and I don't have a lot of experience with that aspect of it, then that sounds great. Otherwise, I think I would explore with her whether she fits the criteria for opiate use disorder, and that's a different sort of story and a different approach, I suppose. If it looks like she's only been using opiates for 3 months, then I'm not sure she's really yet at risk for opiate use disorder. I suppose that's a possibility. So I think I'd want a little bit more information about that aspect of it. But if you think that using buprenorphine for pain relief helps, after giving it, how quickly are you going to see something? Is that going to help out her pain, et cetera?
Yes. I agree. I don't think she has opioid use disorder. With that being said, if she was on it for a couple more months, she would maybe meet some of the criteria for opioid use disorder, at least mild. I would be using it mainly for pain to help prevent her from going down a path of hyperalgesia. And I don't know exactly how quickly it would necessarily work immediately for the pain. Yeah, these people do tend to get some pain relief pretty quickly, but they're usually on it for a longer period of time than this girl was. But at the same time, her poor compliance, having a more organized setting, and having a medication that will help hopefully prevent her from abusing the medication. I do think that she was using it at a higher rate than was prescribed for her. And she was supposed to have been off the medication already and was continuing to use it. This was at 3 months out. She wasn't supposed to be using narcotics anymore, and her surgeons were actually kind of fed up with her.
Yeah, you bring up great points, because I think that she falls into an area that there's not a lot of support or resources for. Like, our pain providers don't often, there's only a handful of them that are willing to even consider buprenorphine as an alternative for pain in patients that don't have opioid use disorder. I am seeing more use of the transdermal formulation, Butrans patch, but I think there's some insurance issues around that. There are some formulations now that have only indicated for pain. The buprenorphine formulations, Belbuca, which is sub-milligram doses, although when patients are on higher doses of full agonists, I usually, if I'm, in most of the patients I'm working with are dual diagnosis, addiction and pain, or opioid use disorder pain. It seems like they need a little bit higher dose of buprenorphine than just the sub-milligram doses. Plus you get the benefits of blocking in addition to pain. So it's a very challenging area, and weaning patients appropriately, if someone determines that this isn't really ideal, there's a need for specialty service to do that, and people really fall through the cracks, and they end up in the emergency department time and time again. So, this, and often, if we get a consult for them, I'm thinking we need more information. It'd be great to gather it over time, but how are we going to do that? Because they're going to what they're doing is repeatedly using the ED for they're coming in, running out, coming in, running out. It probably is some degree of opioid use disorder. This is where some urine screens to find out, are there other things that they're using? Are they taking the opioids? What opioids are there that would be really useful to help? So I'll often recommend, let's get a urine screen in this patient. It's going to give me some information I can go back to. And for many of these, I'm considering starting buprenorphine to at least stabilize, and then we can go from there. And usually preface the patient, this is a different opioid. It's easier to taper if we need to. Let's just see how it goes, and then we do use it for pain and kind of go through exactly what I just ran through with. There's a transdermal patch, there's other opioids, formulations that are only for pain, and we can see kind of where you fit in. So I would consider definitely trying buprenorphine in a patient like this, and all the while gathering more information. Lori, do you want to say anything? You run into patients, get consults, I know, from a pain service, neurology, about buprenorphine for pain?
Yeah, sometimes we do. And in terms of taking them into the state-regulated chemical dependency program, we have to get information that they have progressed to use of other opiates or qualify for opiate use disorder in some way. The thing I always wonder about when you mention giving opiates, giving Suboxone for pain, is that I worry that now that a lot of providers know all about buprenorphine, they will see it on the prescription management program database or wherever, and they will make assumptions that the patient has an opioid use disorder. So I wonder how you would be separating that in the chart, and what sort of descriptive precautions you might take. Because right now, I think most people would assume that someone getting prescribed this would have quite a history of opioid use.
Oh, I think that's great points, and can be one of the pitfalls of having some information available through like the iStop in New York, but not all of the information, because it's not going to link back to a diagnosis. It would be uncommon that there's not, that I'm not seeing a patient and recommending buprenorphine for pain, that there's not been a lot of other opioids and stuff went wrong, and because that's how I'm coming in. I'm not doing a primary pain service or anything. But I think documenting clearly and having a discussion with the primary, that this is why we're recommending buprenorphine, safer opioid, more reasonable in terms of side effect profile, and in the hospital patient tolerated, documenting all that. And then I usually, if we do recommend in the hospital transitioning to buprenorphine, it's a phone call to the primary, and often letting them know that they can use it off X waiver. They don't need the X waiver for pain diagnoses. And, a lot more recently, people have been receptive. In fact, we're getting some consults from a pain service saying, we think that this patient would probably be better from buprenorphine, but only one of our providers prescribes it. Do you know anyone in the community that would be able to take the patient for pain? Or we do more procedures. So our pain service is actually recommending more frequently, which suggests, my question to them is, why don't you add it to your armamentarium a little bit? I think in the next few years, and more, we're going to see more and more of a shift to use of buprenorphine primarily for pain, and we're going to have to sort out all of these things, because there's a lot of potential problems with that misdiagnosis or misattributing, what it's for. Does anybody else, Jade, you had some questions or comments?
Yeah, so we recently went to a conference ACMT hosted on opioids and public policy and the law, and there was a good lecture that kind of described this very, very patient presentation of hyperalgesia, tolerance, kind of how those are two very separate things that can come across clinically as the same. Patients are asking for more medications. They might be running out for one reason or the other, and if it's because of tolerance, that their tolerance is increasing, then the answer, if they're having more pain, is actually that they would need more opioids to kind of keep up with the tolerance that's progressing. And is this truly an opioid use disorder, It's a very complex thing, and I think we just have to be very careful about how we're asking our questions and how we're evaluating these patients, because we might actually be provoking tolerance or invoking tolerance. And then for hyperalgesia, the treatment of that is to stop the opioids completely. And these things can come across clinically very similar. And I think this case kind of brings across this point of can we stop the cycle in its tracks, and is buprenorphine the answer? And I think for this patient, hopefully it is.
All right, let's return to the case.
So I already kind of talked about what we were thinking about, and I called our pharmacy because I hadn't induced anybody at this hospital yet, and we only have IV. We don't have sublingual buprenorphine. So next slide. So a little bit of the workup. I didn't have the chart, access to the chart anymore because I couldn't remember what medical record number was. But essentially, I didn't find anything wrong. I did do a CT of her belly just to make sure I wasn't missing anything. Oh, she had a low-grade obstruction. So we ended up shipping her out to the surgeons 45 minutes away. But it still brought about the question, since we didn't have sublingual, you can go to the next slide. Is it possible to even do an IV buprenorphine induction? How would I do that? What's an equivalent dose for a test dose and then a first day's dose? I'd be able to get her sublinguals from a pharmacy following up, likely, but would I be able to induce with an IV should the opportunity arise in a different patient? Next slide. And then the question also is this even a legal thing to do, since if I'm using it to truly induce for like an OUD picture, this girl didn't necessarily have OUD, but if I'm using it to induce for OUD, this was a ASAP throwaway journal, but someone made the point that we'd be using the IV formulation off-label, and due to the Harrison Act, that could be illegal. So can you even use IV legally to treat an opioid use disorder patient?
Yeah, that's an interesting question. That's a great question. Not all hospitals have the sublingual formulation available, and I've heard of a couple, even in New York, a couple of hospitals that should have the Buprenex available, but not but they haven't had other formulations. So, what do people think? I think, Ingrid, you've commented in some previous lectures about using different formulations, but also you're not in the U.S., so there may not be the same regulations. Does anybody have any comments or questions about this? Derek. Okay, Derek, maybe you first, and then.
Yeah, I guess to answer the question of whether it's legal or not, I would presume that if we're both morally and legally using buprenorphine to treat acute opioid withdrawal symptoms, then it should be regardless of the way that it's administered. The pharmacology is going to be a bit more complicated just because it begs the question of, well, it's different kinetics. So how are we going to use this, and then how are we going to are we going to bridge this patient to a more standardized kind of oral or film therapy? So I think that you have a couple of things to stand on. I mean, if this is what your pharmacy has, but this is a great question. I'm interested. Has anyone used this from a standpoint of maybe not primarily to do an induction on a patient, but to treat withdrawal symptoms, and then how did they transition to non-parenteral medication? So I think the legality is not an issue. I think the question is how do we transition them to something that we use on the outpatient basis?
Lori, do you have thoughts about this as well? Or Ingrid first, I'm sorry, you're still go ahead and comment, and then we'll go.
I can't comment or answer about the IV buprenorphine because I've never used it IV. But from an organizational perspective or an administrative approach, I think this is a wonderful opportunity as medical toxicologists in a community hospital or any hospital to engage the therapeutics committee or whoever it is that decides what goes on hospital formulary, to advocate for patients, of which there are so many out there with opiate dependency, and to get sublingual or outpatient, non-IV buprenorphine that you can use in the ED. EDs are starting, they're doing Suboxone inductions more and more. That's more of the standard. So I think it's an opportunity to flex our medical toxicology knowledge and muscle and push to have therapeutics committees and formulary decision makers get with the times and get this medication on board.
Yeah, those are great. Gloria, and then we can go back to Henry.
No, I just want to second what Ingrid said. Those were great comments. It strikes me that using anything IV when you can use something PO is just a waste of resources. And I've not heard of this being done around here. Of course, most of our hospitals have PO buprenorphine available.
Yes, and but when it's not available, isn't an option. Henry, do you have a comment?
Yeah, I mean, there's this ED bridge protocol that's going around. I think the folks at Highland put it together, and one of the recommendations that they make in that is to use the IV formulation for patients who aren't able to take PO. Having said that, I don't see anything cited in the protocol. They do say start with the 0.3 milligrams IV/IM, may repeat as needed, switch to sublingual when tolerated. But if you Google ED Bridge, their whole protocol for starting buprenorphine in the ER comes up, and it might be worthwhile to reach out to them and see if they have what their experience is with that, what their reason is for using that, and what their thoughts are on the legality of using the IV formulation.
Yeah, but this is Tim. This is interesting because not being able to take PO isn't a reason not to be able to give buprenorphine. In fact, we do inductions in still intubated patients in the ICU that are having challenges with, sedation wean because of high degrees of opioid dependence, and we'll have them on fentanyl, turn that off, have the other setters on, and just put it in buccal buprenorphine. There's a poster at the DC ACMT conference that kind of we described this at. So I don't know why we would unless you just didn't have it available. I'm not sure why you'd need to use IV buprenorphine. And in fact, I worry a little bit. I'm seeing more and more people injecting buprenorphine, both formulations, the dual product and the mono product. And if a patient in the ED gets an IV formulate of buprenorphine, we're just going to give it IV. It's you can do that IV to me potentially. So I didn't know that was part of the Highland Bridge protocol. I'm going to have to look into that. That's very interesting. That would be used. So, but like where you can't I would consider it, but I guess I'm not sure if it's legal or not. To bring up great questions. So go ahead. I just advanced the slides. Brian, let's get a few minutes.
Yeah, these are just some more questions. If you would do a dosing of it, we kind of discussed that. And the next slide. And I think this is my last slide, just the Buprenex liquid formulation of it. So
it's on our algorithm. Go ahead.
Go ahead.
Sorry. I was going to say Buprenex is on our algorithm for the treatment of pain in patients with opioid use disorder, but it specifies specifically pain. When patients come in on opioid agonist therapy, buprenorphine, they get an extra dose. The dose is split. The doses are increased. Usually, if it's just like a procedure, like a fairly large abscess IND where the patient's uncomfortable, we'll go 300 micrograms over 15 to 30 minutes, kind of, slow, infusion, and they tolerate that fine, but it differentiates pain instead of dependence. Now, we've recently also thought about this in transitions. We had a severe multi-trauma patient, and she was on buprenorphine, former patient of mine, bad traumatic brain injury in the past, emotionally labile, struggled with follow-up. She was truly a harm reduction kind of focus in the outpatient setting, and then she had a multi-trauma, and the consult to the tox service was, we can't get her off of IV opioids. She, is truly in pain, but we try and wean, and she has a fit, thrashes around, and she's only tolerating basically being really somnolent to the point really where it's dangerous. We need to make some headway. What are your thoughts? Would have been an incredibly challenging induction. Ultimately decided to go with methadone instead of that, where we're going to run into issues because she truly has severe opioid use disorder at some point, and getting her into opiate treatment program will be a problem. But we had thought about using buprenorphine, doing this slow transition called, I'm blanking on the name of the Bernese method, where you can leave the patient on full agonists and add really microdosing of buprenorphine on top of the full agonists, and then at some point, bit by bit, the buprenorphine replaces the full agonist as the primary opioid at the receptor without precipitating withdrawal. And people are doing this with the transdermal buprenorphine. The Butrans patch goes on top of patients with full agonists without any problems. So it can be done. It's just how would you exactly dose that? The true Bernese method isn't. It's an interesting transition from using heroin outpatients, like a description of how to titrate down while you're still using a buprenorphine, and it's only a case report, so I'm a little skeptical that the way it's described worked, but I do believe that there would be a way of transitioning from full agonists to buprenorphine without stopping the full agonists, and how to do that will be, and to clearly describe that and watch it will be really interesting. At some point we'll probably be trying that. Any other comments or questions? And we have a couple other cases, but I'm trying to stick to close to an hour instead of go on, and we'll save the transitions from fentanyl and the other cases that we have for next month. Does anybody have any other comments or questions? And we'll close the session otherwise. Derek, your hand's still up. Did you have another comment, or is it left up? Henry, you just raised your hand.
Yeah, I had a question back from the other case that I didn't get a chance to ask about, how people are using acamprosate. The way I've read of it and been told of it is that it really helps people maintain abstinence, and that some people have advocated for waiting to start giving it until someone is through withdrawal, yet its mechanism of action, some of its sedative effects, I would think would be helpful during the withdrawal and kind of like post-acute withdrawal standpoint. So I was just curious how people, in what settings, I heard somebody was advocating say that, it'd be reasonable to give out of the ER for someone who is withdrawing, or if people are starting inpatients on it as a way to start therapy.
So to clarify, this is Tim, and then I'll let Dr. Bashevitz comment. I would start this after the acute withdrawal was done, like the day after or right at the tail. I don't think it's interesting. That may be some benefits for, some tail end withdrawal treatment, but I think it seems reasonable to start with naltrexone. By itself, it doesn't seem to have a lot of benefit, but when naltrexone is added, the two together have better markers, have a better effect on markers of drinking from my interpretation of literature. So, Gloria, what do you think?
Well, so my understanding of this whole question was that the initial papers that established the effectiveness of acamprosate only started the acamprosate after the person was out of the woods with the withdrawal, was abstinent from alcohol. And in fact, when acamprosate came out, it was more expensive, of course, and insurances did not want us to give it to people who were drinking anything at all because of this. So I think they've stepped back on that now, but I don't think there's any direct harm that comes from giving it at the tail end of withdrawal. It's just thought to be more effective when it's used in a person who's not drinking. Sometimes it's more practical, though, to start it when you can. And if the patient is still drinking, I don't see a problem with that.
Great, thanks.
Okay, good. Thank you. All right. Well, thank you all for joining. This session is recorded and should go up on the website if there's any interest. Thank you for presenting, Brian and Jade as well. If anybody has any cases that they're interested in presenting, just send an email and then we'll try and get the slides in advance. I'd really like to have some other additional cases, and then we'll be back in January for the Third Friday Conference. Happy holidays, everyone, and travel safe and all that. Thank you.
Happy holidays. Thanks a lot.